Okay, imagine this. A severe allergic reaction strikes, like really suddenly.
Seconds?
Count, right. And yet, the advice on how to handle it, it can be shockingly inconsistent, even among medical professionals.
Yeah, that's absolutely right.
So today on the Deep Dive, we're going to try and cut through some of that confusion. We're tackling one of the most urgent medical emergencies, anaphylaxis.
It really is a condition where knowing the right steps, it can literally save a life. But as our sources show, and we're looking at a rapid review of advanced life support guidelines and also an article debunking common myths, there's actually a surprising amount of, shall we say, outdated info and conflicting advice out there.
That's the core of it, isn't it? We're talking about a serious systemic allergic reaction. It happens fast, and it can be life-threatening.
Mm-hmm.
You'd think for something that critical, the instructions would be crystal clear, totally straightforward.
Mm-hmm.
But the reality is, well, it's quite different.
It really is. And the challenge, I think, for anyone trying to be properly informed is figuring out what's actually evidence-based amidst all that noise, Anaphylaxis itself doesn't change depending on where you are in the world, but the guidelines, they often do. And that creates real confusion for practitioners and for patients, too.
Right. So our goal for you today is pretty simple. We want to distill the most vital, the most evidence-backed knowledge from these sources we've looked at. The aim is that you can walk away feeling confident, clear on what really matters when it comes to anaphylaxis.
Yeah, giving you that clarity.
Exactly. This deep dive is all about that. So let's dig in.
Okay.
So maybe to start, what exactly are we talking about when we say anaphylaxis? I mean, it sounds pretty scary, but what does it actually, mean?
Okay, so at its core, anaphylaxis is a serious systemic hypersensitivity reaction. Systemic is the key word there. It means it's affecting multiple body systems all at once, not just, say, a localized rash.
Right, the whole body.
Exactly. It's usually rapid in onset, and critically, it may cause death. Now, it's not as rare as some people might think either. Some studies estimate about 1 in 300 people will experience it at some point in their lifetime.
1 in 300, wow.
Yeah. And in Europe, the numbers suggest somewhere between 1.5 to almost 8 cases per 100,000 people each year. That's actually quite a significant number when you think about it.
1 in 300 people.
Mm-hmm.
That's probably someone you know, or maybe even you listening. But okay, despite how serious it sounds, our sources also offer a little bit of reassurance on the prognosis, don't they?
They do, yeah. While it's true that hospital admissions for anaphylaxis seem to be, unfortunately, on the rise globally, the overall prognosis is generally good. For people who actually get to a medical facility, the case fatality rate is, it's actually under 1%.
Under 1%. That's lower than I might have guessed.
It is. And even in the UK, where they've seen increasing admissions over the last 2 decades, there hasn't actually been a corresponding rise in fatalities. So yes, it's definitely life-threatening, but it's often manageable if you get prompt treatment.
Okay, that's a really crucial distinction. But manageable really hinges on prompt treatment, doesn't it? Which brings us right back to this core problem, these inconsistent guidelines. Everyone seems to agree that adrenaline or epinephrine, same thing as the first-line treatment. Like, that's universal.
Absolutely non-negotiable.
But what happens next? That's where our sources point to some, surprisingly inconsistent advice once you move beyond just the adrenaline.
Yeah, that's precisely where it gets complicated. There was a rapid review by McClure and colleagues, for instance. They looked at 8 international guidelines and 5 national Australian ones. And they found considerable variation, particularly when it came to what to do if someone actually goes into cardiac arrest during anaphylaxis. Some guidelines were incorrectly recommending things like antihistamines and corticosteroids in those cardiac arrest situations.
Would you have no role there?
Frankly, no. They have no established role in cardiac arrest from anaphylaxis.
And it's quite striking, isn't it, given how serious anaphylaxis can be, that many of these other interventions, they seem to lack really high-level evidence.
It is surprising.
Our sources even use this kind of parachute analogy.
Yeah.
Like with parachutes, you just assume not using one is incredibly dangerous, right?
Obvious, yeah.
But with anaphylaxis, apparently about 80% of reactions actually resolve without adrenaline. Now, that doesn't mean you shouldn't use it.
No, absolutely not. It's still critical to use it.
Right. But it highlights how much of what we think works, or maybe what's become common practice, isn't always backed by really robust data.
Exactly. I think the key takeaway here is that adrenaline is non-negotiable. It's the first-line treatment, period. But beyond that, for these other interventions, we really need to be discerning about the evidence, or sometimes the lack of it.
Okay, so let's dive deeper into adrenaline then. because there seems to be this pervasive fear out there, what our sources call myth number 4, that adrenaline itself is dangerous. What's the actual truth?
Yeah, that's one of the biggest misconceptions, and it's a dangerous one because it leads to hesitation. The fact is, adrenaline, when it's given by intramuscular injection, that's IM, into the outer mid-thigh, it's actually very safe, and it's incredibly fast-acting, usually works within minutes.
Wow, minutes?
Mm-hmm. And it's truly the only drug that effectively reverses those profound physiological changes happening during anaphylaxis.
How does it do that?
Well, it does several things at once. It causes peripheral vasoconstriction. That means it narrows blood vessels, pushing blood back towards your vital organs. It increases cardiac output, helps your heart pump better. It causes bronchodilation, opening up the airways so you can breathe easier. And importantly, it suppresses the further release of those inflammatory mediators, the chemicals that are driving the reaction in the first place.
So it's really doing a lot of heavy lifting across the whole body. And the timing. Timing is absolutely everything here, isn't it?
It really cannot be stressed enough. Delayed adrenaline is explicitly linked to poor outcomes, including death. That's what the sources clearly show. Now, patients might experience some transient side effects, maybe some pallor, feeling anxious, palpitations, maybe a headache. But here's the thing. Those can also be symptoms of the reaction itself, or even just your body's own stress response, the endogenous adrenaline kicking in.
Right, so it's hard to tell what's the drug and what's the reaction.
Exactly. The real danger isn't the adrenaline itself. It's the consistent underuse of it. That's the problem we see time and again.
It almost sounds like we're, I don't know, afraid of the solution sometimes, even when it's right there, ready to use. Imagine being in that critical moment, seconds ticking away, and you hesitate. That's a truly terrifying thought.
And it happens far too often. Despite its safety profile and its proven effectiveness, adrenaline is consistently underused, both before someone gets to the hospital and even once they arrive in the emergency department.
So how should it be given?
For administration, it's IM adrenaline, intramuscular, at a 1.10000 concentration. That's recommended. And it's also important to know that the standard auto-injector doses, the 150 microgram or 300 microgram ones, they might actually be an underdose for larger individuals.
Oh, really?
Yeah, specifically for those over 30 kilograms or perhaps even over 25 kilograms for younger children. And if the symptoms persist after that first dose, repeat doses should be given after about 5 minutes.
Okay, 5 minutes. Got it. But what if a reaction becomes, really severe? Our sources mentioned something quite shocking, that in severe anaphylaxis, up to a third of your circulating blood volume can effectively leak out of the blood vessels in just minutes. That sounds catastrophic. What do doctors do then?
Yeah, when a reaction gets truly severe and you're potentially losing that much fluid from your circulation so rapidly, doctors need to act very aggressively.
Right.
That typically means using powerful, continuous adrenaline, but given through an intravenous line, an IV, or sometimes intraosseous, that's IO, meaning into the bone marrow, usually reserved for emergencies when getting IV access is tough.
An infusion, not just a shot.
Exactly, an infusion. Yeah. And that needs to be coupled with rapid fluid resuscitation. We're talking sometimes 3 to 5 liters of crystalloid fluid, which is essentially a saltwater solution, just to restore the circulating volume. And if it escalates all the way to cardiac arrest, then an intravenous bolus administration that's a quick push of adrenaline is needed. Again, supported by IV fluids and, of course, CPR. The goal is really aggressive, immediate intervention to stop that circulatory collapse.
Okay, that clarifies adrenaline's absolutely crucial role and how it's used in different severities. But what about all those other treatments people often reach for? The ones they're convinced are helping. Let's dive into some more of these common misconceptions, starting with antihistamines. Our sources flag myth number 5. Antihistamines can be used to treat anaphylaxis initially.
Right. Well, the evidence tells a very, very different story here. Antihistamines are not a first-line treatment for anaphylaxis, not at all.
Why not?
Because histamine is just one of many inflammatory mediators involved in the reaction. By the time you're having full-blown anaphylaxis, it's a far more complex cascade involving multiple systems and chemicals. Plus, oral antihistamines, the ones you swallow, they take about 30 minutes to even start working.
Way too slow.
Far too slow when seconds count. And the intravenous forms, they can actually cause hypotension, a dangerous drop in blood pressure, which could potentially make the whole situation worse.
So hang on, not only are they too slow, but they could actually be harmful in some cases. It sounds like they're basically a distraction from the real treatment, adrenaline, and might even make things worse if they cause a delay. It's like bringing a squirt gun to a house fire, maybe.
That's a perfect analogy, actually. They simply don't address the systemic nature of the reaction effectively. Any apparent relief someone might feel after taking an antihistamine during anaphylaxis is probably more likely due to their own body's adrenaline kicking in, not the antihistamine itself.
Oh, okay.
So current guidelines have pretty much relegated antihistamines to third-line therapy. They might help a bit with skin symptoms, hives or itching later on. But the critical message, the absolute key point is they must never delay the administration of adrenaline or fluid resuscitation if that's needed. Adrenaline always, always comes first.
That's a really vital distinction. Okay, another common belief. Myth number 6 this time. Corticosteroids prevent delayed or biphasic reactions. What's the evidence say about that?
Unfortunately, again, the evidence just isn't there. There's insufficient evidence to support this claim. And crucially, there have been no randomized controlled trials, the gold standard of medical evidence, that have ever shown corticosteroids prevent these biphasic reactions.
What are biphasic reactions exactly?
That's when the symptoms seem to resolve, but then they come back again, sometimes hours later, typically within 72 hours.
Right. And steroids don't stop that.
Well, a recent systematic review, which looked at over 4,000 cases, found absolutely no effect of corticosteroids on the likelihood of these biphasic reactions happening. In fact, there was even a non-significant trend suggesting they might be associated with an increased risk.
Increased. Why would that?
Yeah, well, it's likely what we call confounding by indication, meaning the steroids were probably given more often in the initially more severe cases, so it wasn't the steroids causing the biphasic reaction, but rather they were used in patients who were already sicker and perhaps more prone to it anyway.
Okay, that makes sense. So not only do they not seem to help prevent that second wave, but there are also maybe some concerns they might increase the need for intensive care admission. This really just underscores the importance of relying on treatments with solid evidence, not just, what's always been done.
Absolutely. We really need to focus on what demonstrably works, especially in an emergency like anaphylaxis.
Okay, let's move on to some diagnostic myths then. Circling back to myth number 1, which suggests anaphylaxis often results in death. You touched on this earlier, but it's such a powerful, pervasive fear, it feels worth reiterating.
It really is a persistent myth, and understandably, it causes a lot of anxiety. But the reality is, while anaphylaxis is certainly life-threatening and needs to be treated as such, fatalities are actually very rare. The case fatality rate is estimated to be under 0.001%.
Less than 0.001%. That's incredibly low.
It is. And the primary contributor to those rare fatalities we do see is almost always a delay in appropriate treatment, usually meaning delayed adrenaline. Now, it's true that severe reactions can be unpredictable, sometimes mimicking milder ones at the very beginning. And that's precisely why all suspected anaphylaxis reactions must be treated as a medical emergency. The goal is rapid, effective treatment to prevent it from escalating.
That makes perfect sense. Treat every suspected case seriously and quickly. Now, here's one that I think could really lead to dangerous delays in diagnosis. Myth number 2, no hives, so it can't be anaphylaxis. Is it always about the skin reaction?
No, absolutely not. And this is such a critical misconception. Many people, even some healthcare providers, can fall into this trap. The truth is, cutaneous symptoms, so that's things like hives, flushing, or angioedema, which is swelling beneath the skin, they're actually absent in about 10% of anaphylaxis cases.
10% is quite a lot.
It is. And even when they are present, they might be delayed, they might not appear right away. The real danger here is that the lack of obvious skin signs can tragically delay diagnosis and, consequently, delay that life-saving adrenaline treatment. Modern guidelines, like the ones from ASCIA, the Australasian Society of Clinical Immunology and Allergy, they explicitly recognize that anaphylaxis can occur with just an acute onset of hypotension, that's low blood pressure, or bronchospasm, tightening of the airways, or upper airway obstruction, even without any of those typical skin features. It's really about the whole clinical picture, not just what you can see on the surface.
Wow. Okay, that is a huge takeaway. You can be in full-blown anaphylaxis and have absolutely no outward skin symptoms. That's incredibly important for anyone listening, whether you're a first responder, a teacher, a parent, anyone caring for someone with allergies.
Absolutely critical.
And what about when you just can't figure out the trigger? Myth number 3 says no trigger for the reaction is identified, therefore it is not anaphylaxis.
That's another myth we definitely need to debunk. Approximately 20%, so 1 in 5 cases of anaphylaxis, are considered idiopathic.
Idiopathic meaning?
Meaning no specific trigger is immediately identified. Often, this might be due to undisclosed or hidden food allergens, maybe cross-contamination, something the person wasn't aware they consumed. But the key point is, Diagnosis is primarily clinical. It's based on the signs and symptoms the person is presenting with at that moment.
So tests don't rule it in or out.
Well, lab tests, like measuring mast cell tryptase, or MCT, that's a chemical released by certain immune cells during a reaction, they can be supportive, they can help confirm things later, but they're not specific enough for anaphylaxis. The results certainly aren't fast enough for acute management in the moment. And importantly, MCT levels are often not raised even in severe or even fatal food-induced reactions.
So a negative test doesn't mean anything in the moment.
Exactly. A negative MCT test absolutely does not rule out anaphylaxis. You have to treat based on the clinical presentation.
That's also fascinating about the diagnostic criteria differing internationally. Our sources mention how, say, the U.S. NIAID criteria might classify just skin and gut symptoms together as anaphylaxis. But in the U.K. and Australia, for food reactions anyway, you typically also need respiratory or cardiovascular symptoms involved.
That's right.
That could significantly impact whether someone gets adrenaline, just depending on where they happen to be, right?
It really could. It highlights the need for maybe more harmonization in guidelines globally. And another really crucial point from the sources on triggers. The most common food trigger for fatal anaphylaxis in children in the UK isn't nuts, as many might assume. It's actually milk.
Milk, really?
Yes, milk, followed by peanut and tree nuts. Milk allergy is often underestimated, I think, in terms of its potential severity, but it can be very dangerous, particularly when it occurs in someone who also has asthma.
Which brings us neatly to risk factors. Can we actually predict who's most at risk for severe anaphylaxis? Is that possible?
Honestly, it's very difficult, if not impossible, to accurately predict on an individual level. We know certain things increase risk, like having a previous history of anaphylaxis, obviously. Exposure to known high-risk allergens like peanuts, tree nuts, seafood. Certain patient factors, too, like being a teenager or young adult seems to be a higher risk period. Having unstable or moderate to severe asthma is a big one. Or having underlying mast cell disorders. Even things like limited access to emergency care can be a risk factor.
What about asthma? You mentioned that. How big a factor is it?
Well, asthma is common in people with food allergies. Maybe around 50% have both. But interestingly, just having asthma has relatively poor predictive value for predicting severe anaphylactic reactions. What is clear is that managing asthma well, keeping it under good control, definitely reduces the overall risk if an allergic reaction does occur.
Okay. So lots of potential factors, but no crystal ball.
Pretty much. But the one thing we do know for sure, the most critical identifiable risk factor for fatal outcomes, it comes back to that delay in treating with adrenaline. That's the consistent finding.
Timely treatment is the undisputed key then. Okay, let's shift gears slightly and talk about adrenaline autoinjectors. They're a cornerstone of management for many people, but there's a common belief, myth number 7, that only children who have had anaphylaxis need an adrenaline autoinjector. What does the evidence actually say about who needs one?
Yeah, that's a misconception that could unfortunately leave quite a few people vulnerable. Given our inability to accurately predict who will have a severe reaction, the decision to prescribe an autoinjector is generally based on a broader risk assessment, not just on whether someone has had a prior anaphylactic event.
So you don't have to have had one before to need one.
Exactly. Not having had anaphylaxis before might simply mean you haven't had a significant enough exposure to your trigger yet. It doesn't mean you lack the underlying predisposition. And related to that, there's also no good evidence that allergic reactions inherently get worse with each subsequent exposure. That's another common myth. Nor is there strong evidence that anaphylaxis risk runs in families in a simple, predictable genetic way.
Okay, that dispels some pretty widespread anxieties, I think, and it broadens the scope of who might need to be prepared with an autoinjector. Now, on the flip side, myth number 8 suggests adrenaline autoinjectors are overprescribed and overused. But our sources seem to indicate the complete opposite is true.
That's absolutely correct. The evidence points strongly towards autoinjectors being significantly underused in the community when they are needed.
Why is that? Why are they underused?
There are several reasons, it seems. Sometimes caregivers don't recognize the severity of a reaction early enough. Sometimes the autoinjector just isn't available at the time of the reaction. Maybe it was left at home or at school. There can be uncertainty or even fear about how to actually use the device correctly. And sometimes people just don't carry it consistently, maybe because of the size or design of the injector. These are all significant barriers preventing timely treatment.
So it's not just about having the device prescribed, it's about having it with you and knowing when and how to use it confidently. Which leads us nicely into myth number 9. Prescription of an adrenaline autoinjector in isolation is life-saving. Is just having the pen enough?
No, and this is a really crucial point. An autoinjector is just one part, albeit a critical part of a comprehensive management plan. Optimal management really involves a holistic approach, meaning things like strict dietary avoidance if it's a food allergy, thorough patient and caregiver education on recognizing symptoms and how and when to administer the treatment, and also addressing the psychosocial aspects, the anxiety and lifestyle changes that come with living with severe allergies. The autoinjector buys you invaluable time to get to emergency care, but it needs to be used correctly and as part of that larger framework of management.
And using it correctly means more than just, taking off the cap and pressing the button. Our sources really highlighted the importance of patient positioning during a reaction. Can you explain why that's so critical?
Yes, it's absolutely critical and often overlooked. Proper positioning can literally help prevent a patient from deteriorating rapidly or crashing. The recommended position is lying supine, so flat on their back with their legs elevated.
Legs up.
Elevating the legs helps return blood to the core, supporting blood pressure. Now, if someone is having significant respiratory symptoms like difficulty breathing, they might feel more comfortable sitting up. If they do sit, their legs should still be elevated if at all possible. The absolute key thing to avoid is sudden standing or walking.
Why is standing bad?
Because in anaphylaxis, blood vessels dilate massively and blood pressure can drop precipitously. Standing up suddenly can cause blood to pool in the legs, leading to a catastrophic fall in blood pressure, circulatory collapse, what we call decompensation, and potentially fatal events have been linked to patients trying to stand or walk during a reaction.
Wow. Lie down, legs up. That's vital.
It really is. And just quickly on the devices themselves, there's still some debate about how many autoinjectors people should carry. In the UK, the MHRA, which is their regulatory agency, recommends carrying 2. That's mainly due to potential uncertainties about delivery or if the first one misfires or isn't used correctly. However, the main allergy body, BSACI, suggests that 1 is usually effective, so there's a bit of differing advice even there.
Right. The key thing is to have at least 1 readily available and know exactly how and when to use it, plus the positioning.
Precisely. It's a multifaceted approach. Education, avoidance, having the device, knowing how to use it immediately, correct positioning, they all play a crucial role.
Okay, finally, let's clear up a common concern around vaccinations, specifically relating to egg allergy. Myth number 10 says, MMR and influenza vaccination are contraindicated in patients with previous anaphylaxis to egg. What's the actual story there?
Yeah, this is a really significant misconception, and unfortunately, it can prevent people, especially children, from receiving vital protection against serious diseases. Let's take the MMR vaccine first. That's measles, mumps, rubella. It is grown in chick fibroblast cells, not whole eggs, and it contains no detectable egg protein.
None at all.
No detectable egg protein. So egg allergy, regardless of how severe it is, even including previous anaphylaxis to egg, is not considered a contraindication to receiving the MMR vaccine.
Okay, that's a huge relief for many parents and individuals who might be worried about vaccine safety with egg allergies. What about the flu shot, the influenza vaccine?
Right, so for influenza vaccines, they are prepared using viruses grown in hen's eggs, and they can contain very, very low levels of ovalbumin, which is an egg protein. However, a large amount of recent data confirms that both the injected flu vaccine and the intranasal spray form are actually safe for egg-allergic children and adults too, even those who have had previous anaphylaxis to egg.
So generally safe even with egg allergy?
Generally safe, yes. These vaccines can typically be given in primary care settings, like your GP's office, using the standard precautions that are always taken with any vaccine. The only potential, extremely rare exception might be individuals who have had a previous life-threatening reaction to egg that required intensive care.
Which is vanishingly rare, you said.
Vanishingly rare, yes. In those specific, very rare cases, giving the vaccine in a hospital setting might be considered perhaps more for reassurance than anything else, but even then, the available data suggests it's likely safe.
Good to know. So MMR and flu shots are largely okay for people with egg allergies. But there is one egg-related vaccine where caution is still very much needed.
That's correct. The yellow fever vaccine. This one does contain small amounts of egg protein, and it has been documented to trigger anaphylaxis in some egg-allergic individuals. So for the yellow fever vaccine, if you have an egg allergy, you need to consult with specialist centers that have protocols, sometimes involving desensitization, to manage the risk. It's a key distinction to be aware of.
Okay, that's clear. Wow, this deep dive has really unpacked some incredibly critical truths about anaphylaxis, hasn't it?
I think so.
We've seen that, yes, it's a serious condition, but it is generally manageable We've reinforced that adrenaline is the safe, absolutely essential first-line treatment, and that using it quickly, without hesitation, is paramount.
Mm-hmm. Critically important.
Yeah. And we've also debunked quite a few common beliefs about diagnosis, like needing hives, and about other treatments, such as antihistamines and corticosteroids, which, the evidence just doesn't seem to support for acute management or preventing biphasic reactions.
Indeed. And hopefully understanding these facts is genuinely empowering for you listening. It allows you to be better prepared, maybe to recognize symptoms more accurately, and certainly to advocate for the most appropriate evidence-based management, whether that's for yourself, your child, or someone else you care about.
Absolutely. Knowledge really is power here. So what does all this mean for you, the listener? Given these inconsistencies we've talked about in international guidelines and these persistent misconceptions that are still out there, how might this actually impact global healthcare standards? Or maybe even just your own personal preparedness? And perhaps, what role do you think we all play, patients, caregivers, healthcare professionals, in pushing for clearer, universally accepted guidelines and making sure everyone understands the real facts about this potentially life-saving information? Definitely something to think about.